Hi students, today we are going to discuss about some important aspects of pediatrics questions that are known to be asked in NEET PG or next PG examination. Okay, let's start our session now. Right, look at this. The first question is this one. A 8-year-old, first question. A 8-day-old breastfed baby presents with vomiting, poor feeding, and loose stools. On examination, the heart rate is 190 per minute. It means the heart rate is increased. Heart rate is increased, BP 50 to 30. So BP is decreased. Respiratory rate is increased and capillary refill time is 4 seconds. So what does it mean? The child is in shock right now. The child is in shock right now. Investigation revealed sodium 120, potassium 6.8, chloride 81 and bicarbonate 15 milliequivalent per liter with urea normal, creatinine normal. So you have hyponatremic, hyperkalemic, metabolic acidosis. So you have, one second. So what you have right now? Right now you have, so right now you have the child is in shock, point number one. Second point is hyponatremia. The child has hyponatremia. The child has hyperkalemia, and bicarbonate is less. The child is having metabolic acidosis. The child is having metabolic acidosis. In which condition you will get this one? In which condition you will get this one? The answer is simple. So in which condition you will get this one? So you have hyponatremia, you have hyperkalemia, you have low bicarbonate, that means metabolic acidosis, and then the child is in shock. And this is a neonate. So this is the condition. You all know that aldosterone is the one which absorbs sodium, and it absorbs sodium and absorbs, aldosterone is the one that absorbs sodium and it excretes your potassium and bicarbonate. So when aldosterone is absent, what will happen? You will get hyponatremia, you will get hypokalemia, and because of hydrogen retention, you will get metabolic acidosis. So in which condition you will get this hypoaldosteronism? In which condition you will get this hypoaldosteronism? One condition is called congenital adrenal hyperplasia. So look at this, congenital adrenal hyperplasia. In case of acute tubular necrosis, your urea will be high, creatinine will be high. So this is unlikely to be acute tubular necrosis. In case of congenital hypertrophic pyloric stenosis, what will happen? You will vomit out sodium, you will vomit out chloride, you will vomit out sodium, you will vomit out chloride, as a result of which hyponatremia will occur, hypokalemia will occur, but because you are vomiting hydrogen ions in the stomach, you will get metabolic alkalosis, but here metabolic acidosis. So this is also ruled out. Galactosemia will be associated with hypoglycemia and liver failure. Will be associated with hypoglycemia and liver failure. So the answer for this first question is, congenital adrenal hyperplasia. Most common cause for congenital adrenal hyperplasia is 21 alpha hydroxylase deficiency. And what is the investigation of choice? 17-hydroxyprogesterone. The investigation of choice is 17-hydroxyprogesterone levels in the blood. Okay, right. The next one. A 3-month-old child with normal genitalia presents to the emergency department with severe dehydration, hyperkalemia, and hyponatremia, like the previous case. The measurement blood levels of which of the following will be useful? Again, the answer is 17-hydroxyprogesterone, which is the marker of congenital adrenal hyperplasia. You have 21 alpha hydroxylase deficiency, and you have 11 beta hydroxylase deficiency. So in 21 alpha hydroxylase deficiency and 11 beta hydroxylase deficiency, what will happen? In 21 alpha hydroxylase you have hypotension, whereas in 11 beta hydroxylase you have hypotension. You have hypertension. Right, let me write. So what is the BP? What is the genitalia? What is the BP? What is the genitalia? If the child is male, if the child is female. Point number 1, 21 alpha hydroxylase, in which you will get hypotension. In male, you will get precocious puberty. In female, you will get ambiguous genitalia. Second, 11 beta hydroxylase deficiency, in which you will get hypertension, and in male same precocious puberty, in female ambiguous genitalia. And in 17 alpha hydroxylase deficiency, again you will get hypertension. Here what will happen? Ambiguous genitalia in a male. You will get ambiguous genitalia in a male, and in female normal genitalia. Okay, right. Next question. Which one of the following drug is used for fetal therapy of congenital adrenal hyperplasia? The answer is antenatal dexamethasone. What is the answer? The answer is antenatal dexamethasone. Remember, whenever there is a previous history of ambiguous genitalia. What will happen? As soon as in the next pregnancy, when the mother comes to you, you need to start antenatal dexamethasone. Why antenatal dexamethasone? This antenatal dexamethasone will suppress fetal ACTH, as a result of which your unused precursors will not be converted to testosterone. Right? So you need to give antenatal dexamethasone. From when? You need to start as early as conception, as early as possible. To give as early as possible, and you need to continue till 10 to 12 weeks, and by 10 to 12 weeks, if it is a boy or girl, boy means stop, girl means continue, because ambiguous genitalia is a problem in girl children, but not in boys. That's why this protocol. Our driver phone பண்ணியார். Right. The next question. What is the commonest cause of childhood Cushing syndrome? Is it adrenal adenoma, pituitary adenoma, ectopic ACTH, prolonged steroid treatment? The answer is prolonged steroid treatment. The most common cause for Childhood Cushing syndrome is prolonged steroid treatment because you must be receiving steroids for rheumatic fever, you must be receiving steroids for nephrotic syndrome for about months together. So the most common cause for Cushing syndrome in children is exogenous steroid replacement therapy. Then what are all the other causes? Let me explain you. What are all the other causes? So the most common cause is exogenous steroid. Common cause is exogenous steroids. What is the role of adrenal adenoma and adrenal carcinoma? This adrenal adenoma and adrenal carcinoma produces cortisol, and this is mainly the second most common cause for childhood Cushing syndrome. Right? In case of adrenal adenoma, it is slowly progressive. In case of adrenal carcinoma, it is fastly progressive. Which one? The findings. And remember, adrenal carcinoma produces mineralocorticoids and also testosterone, as a result of which adrenal carcinoma will be associated with hirsutism as well as hypertension. Hirsutism as well as hypertension. The third most common cause is ACTH producing pituitary tumor. ACTH producing pituitary tumor, and it most often occurs during puberty, and it is called Cushing's disease. It is called Cushing's disease. Remember, it is called Cushing's disease. Okay. So now, first one, it can be produced in adrenal. Second one, it can be produced in pituitary. Third one, it can be produced in ectopic. Ectopic ACTH means ACTH. So pituitary ACTH. Ectopic ACTH means it can be produced by Wilms tumor. It can be produced by carcinoids. Right. Carcinoids. What is the how to differentiate between in pituitary ACTH and ectopic ACTH? There will be skin hyperpigmentation. Okay. What is the screening test and what is the confirmatory test? So, what is the screening test and what is the confirmatory test? Screening test is overnight dexamethasone suppression test. Confirmatory test is low dose dexamethasone suppression test. Whereas your high dose dexamethasone suppression test is to differentiate between ectopic or pituitary, because when you give high dose dexamethasone, if the cortisol level falls, then it is pituitary. If the cortisol level doesn't fall, it is ectopic. This is all about Cushing syndrome. Then a 17-year-old girl is being evaluated for delayed puberty. On examination, she is having normal breast development. What is the most possible diagnosis? Right. So what do you mean by delayed puberty? Absence of secondary sexual character by 13 years. 2. Absence of menarche by 16 years. So what is the most common cause? Most common cause is any systemic illness. So after ruling out say systemic illness as well as malnutrition, poor nutrition. After ruling out these things, what you need to do? Very simple. You need to look for two things. How about gonadotropins level? Gonadotropins level, your LH and your FSH. And you need to know your LH, FSH is high, whereas your LH, FSH is low. Your FS-LHS high means ovarian failure. Ovarian failure. That means it is nothing but Turner syndrome. When your LH, FSH is low, you need to rule out what is that syndrome called as Kallmann syndrome. Kallmann syndrome. Or it can be due to hypothyroidism. Or it can be due to hypothyroidism. Kallmann syndrome. Second one is hypothyroidism. Right. Third one is high prolactin. Because high prolactin can mask your LH-FSH release. So your delayed puberty is mainly based on whether it is hypergonadotropic hypogonadism or hypogonadotropic hypogonadism. In these conditions, there will not be any breast development. There will not be any secondary sexual character. But one more condition. What is that one more condition? Look at this. A child, a 17-year-old girl is being evaluated for delayed puberty. On examination, she is having normal breast development. Normal breast development means your LH and FSH are secreted. Your LH and FSH have secreted. As a result of which, the puberty had occurred. Thelarchy means puberty had occurred. But thelarchy should be followed by menarche. But here, thelarchy is not followed by menarche. So what will be the answer? The answer is Mullerian agenesis. The answer is Mullerian agenesis. When you have thelarchy but no menarche, think about Mullerian agenesis. Turner syndrome, you will have hypergonadotropic hypogonadism. Autoimmune polyendocrinopathy is characterized by hypogonadotropic hypogonadism. Sometimes craniopharyngioma can destroy your pituitary gland LH and the FSH, turning again to hypogonadotropic hypogonadism. In all these cases, there will not be any breast development. Here, breast development is present, but there is no menarche. So the answer should be Mullerian agenesis. Next question. A 3-year-old child with severe acute malnutrition is being managed as an inpatient in the hospital for 15 days. The child had no edema. From day 6 and started gaining weight of 10 kg per kilogram per day. Now the child suddenly developed abdominal distension, hepatosplenomegaly, parotid swelling, tremors and gynecomastia. What is this syndrome called as? This is called as nutritional recovery syndrome. What is this called as? This, whenever a child who is on initial stabilization phase suddenly developed hepatosplenomegaly, parotid swelling, tremors, gynecomastia, it is nutritional recovery syndrome. Why is it so? Because it is mainly due to the presence of high quality proteins in the diet. High quality protein in the diet, which in turn leads to the production of estrogen, which is responsible for the manifestation. That's why you need to slowly increase the protein intake while treating a child with severe acute malnutrition. So initially you have F75 formula, then you have F100 formula. So what does it mean? In F75 formula, you have a protein of 2 gram per kilogram, gradually increased to 3 gram per day, and finally you can go up to 10 gram per day. But instead of going slowly, if you start very fast with respect to these protein intake should be gradually increased to 10 grams, such that when you increase your protein intake in a very rapid manner, it will automatically end up in this syndrome, otherwise called as nutritional recovery syndrome, due to estrogen producing hepatosplenomegaly, parotid swelling, tremors, and gynecomastia. Right. So, what is the treatment of choice? The treatment of choice is to step down proteins. The treatment of choice is to step down proteins. Right. So, this is often asked question. Nutritional recovery syndrome. Right. Then, hyperostosis of bones is seen in which hypervitaminosis? Hyperostosis of bones is seen in which vitamin? Is it acute hypervitaminosis, chronic hypervitaminosis? No. Your acute and chronic hypervitaminosis are characterized by hypercalcemia. Hypercalcemia not associated with hyperostosis, whereas acute hypervitaminosis is characterized by pseudotumor cerebri. Pseudotumor cerebri, joint pain, alopecia, and then so hepatosplenomegaly. Which one? Acute hypervitaminosis. Very important question. Acute hypervitaminosis is vitaminosis A is associated with the pseudotumor cerebri. Headache, vomiting. Whereas your chronic hypervitaminosis is associated with hyperostosis of bones. So the answer for this question is chronic hypervitaminosis A. The answer for this question is chronic hypervitaminosis A. Remember, hyperostosis of bones is a manifestation of chronic hypervitaminosis A. Do not get confused with the hypervitaminosis D. Hypervitaminosis D is associated with the hypercalcemia. Then, the diet B plan for the management of persistent diarrhea is, what do you mean by persistent diarrhea? It often due to infection, probably let me say rotavirus 1. And if it lasts for more than 14 days, very important, this is called as persistent diarrhea. Remember, infectious etiology lasting for more than 14 days. In case of malabsorption, which is due to pancreatic insufficiency, cystic fibrosis, Crohn's disease, etc., they are malabsorption syndrome that should not be considered as persistent diarrhea. Persistent diarrhea means post-infectious and it lasts for more than 14 days. Right. Then lasts for more than 14 days. Right. Then what is the treatment? Remember, this persistence of diarrhea more than 14 days means the child has lost what? Lactase enzyme, or it can be due to maltase or sucrase enzymes. These are brush border enzymes which can digest and absorb your lactose, maltose, sucrose. What is diet A plan, diet B plan, and diet C plan? Let me tell you. So what is diet A, diet B, and diet C plan? In diet A plan is reduced lactose diet. That means you are reducing the lactose content to 50 ml per kg. That is called as diet A plan. Second is diet B plan. Diet B plan means no lactose diet. Whereas what is called as no milk diet? What is called diet C plan? Diet C plan is no lactose as well as no starch. So you will get only egg albumin. You will get a chicken soup. That is diet C plan. Diet C plan, it is presumed that not only lactose but also there is starch malabsorption. That is called diet C plan. Very important. So what is the diet A plan? So reduced lactose diet is diet A plan. Lactose free diet is diet B plan. Monosaccharides, no lactose, no starch is diet C plan. That is monosaccharide based diet. This is called diet C plan. Remember, all these diet plan are mainly meant for persistent diarrhea and not due to malabsorption syndromes. Next case. What is this? A 3-year-old child has been referred to tertiary care center with the following features. 2 episodes of pneumonia in the past 6 months with proven radiological with nematocele. Nematocele means air pockets and a recurrent skin abscess needing IV antibiotic. On examination, the child is dysmorphic, pruritic marks and healed scars of abscess are seen. What is the next level of investigation we may order for? Adenosine deaminase, serum IgE, CH50, tetrazolium. Anyone who is attending, can you answer in our chat box? Can you answer in our chat box? What is the answer for this syndrome? A, B, C, D. What is the answer, my dear friends? Okay, let me explain you. So what is that? You need to know something called as what? Fettered. What is that? F, A, D, E, D. F stands for abnormal phases. F stands for abnormal phases. A stands for abscess formation, that is painless abscess formation, and this is called as Jobs syndrome. T stands for double row of teeth. T stands for double row of teeth. Okay, both temporary teeth and permanent teeth will be present. Double row of teeth. E stands for eczema. E stands for eosinophilia. Okay, and then E stands for hyper IgE. D again dermatitis. Dermatitis. So what is this called as? This is called hyper IgE syndrome, which is a combined immunodeficiency involving T cells and B cells. Combined immunodeficiency. So the answer for this question is hyper IgE. So answer is B. Adenosine deaminase is mainly meant for severe combined immunodeficiency. CH50 is for complement assay, whereas nitroblue tetrazolium test is for chronic granulomatous disease. Right? Right. Next question. A term baby delivered by LSCS has not cried after birth and the tone is floppy. So what does it mean? The child is having hypoxia. After initial resuscitation with positioning, suctioning and tactile stimulation, the child is apneic and heart rate is less than 100. So when the heart rate is less than 100, you need to start bag and mask ventilation, which is nothing but positive pressure ventilation. After 30 seconds of bag and mask ventilation, the heart rate is 80. When the heart rate is 80 and the child is apneic, what is the next step? So let us explain. So what will happen? Whenever your heart rate is less than 100 per minute, you need to start positive pressure ventilation, otherwise known as bag and mask ventilation. So you need to do it for minimum 30 seconds. And you need to do whether your heart rate is increasing or not. Now what you need to do, after doing 30 seconds of bag and mask ventilation, you can have heart rate of less than 60, you can have heart rate of 60 to 100, you can have heart rate of more than 100. Heart rate of more than 100 means you are successful, you need to stop bag and mask. Heart rate of less than 60 means you need to start chest compression. Whereas heart rate is 60 to 100 per minute means your bag and mask ventilation is not proper. So at that time you need to do what? You need to take some steps to correct the bag and mask ventilation, because the way you are doing your bag and mask ventilation is false. So what is here? The heart rate is 80. If it is less than 60, start chest compression along with the bag and mask ventilation. If the heart rate is more than 100, start, you need not do any bag and mask ventilation. In between 60 to 100 means what you are supposed to do? Ventilation correction steps. What do you mean by ventilation correction steps? Can anyone tell me what do you mean by that ventilation correction steps? What is that? It is called, what is that? Ventilation corrective steps. So you need to snugly fit the mask. SOPA, Mr. SOPA. So you need to give proper suctioning. You need to open the mouth. You need to put adequate pressure. You need to, if even everything is becomes issue, then alternative airway. Alternative airway means what? Either laryngeal mask airway, or you need to do endotracheal intubation. So M stands for properly applying the mask, R stands for reposition the neck. So when your heart rate is between 60 to 100 after starting bag and mask ventilation, you need to do Mr. SOPA. M stands for reposition of mask, a mask, R for reposition of neck, S for suctioning of mouth, O for adequately open the mouth, P for putting adequate pressure over the bag and mask, A if above, even if all the above things are failed, you need to go for alternative airway. Alternative airway. That's all about that question. Next question. All the following are true statements about newborn except umbilical cord clamping must be delayed for 30 seconds. So this is the recent entry point. Yes, umbilical cord should be delayed. Clamping should be delayed. While cleaning the baby, the vernix caseosa should not be wiped out. Yes, vernix caseosa is the one which is going to maintain the temperature of the newborn. If you completely wipe the vernix caseosa, what will happen? The child is prone for hypothermia. You need to remove the amniotic fluid that is present over the child and not the vernix caseosa. For babies weighing less than 1 kg, 0.5 milligram of vitamin K is administered. The answer is yes. Less than 1000 grams, 0.5 milligram, more than 1000 grams, 1 milligram. Intramuscular, because vitamin K is deficient. Delayed discharge in KMC. What is meant by KMC? Kangaroo mother care. Remember, kangaroo mother care can be started as soon as the child attains 1800 grams of birth weight, and it can be continued till 2500 grams. But remember, the purpose of kangaroo mother care is as early as possible. So triad of kangaroo mother care. So triad of kangaroo mother care. Triad of kangaroo mother care. So what is the triad? Early breastfeeding. What is the triad? Early breastfeeding and exclusive breastfeeding. Second point, skin to skin contact. Second is skin to skin contact. Third one is early discharge, not late discharge. Third one is early discharge. Third one is early discharge. This is all about kangaroo mother care. So kangaroo mother care means early discharge and not delay in discharge. So this answer is correct. False. Right. Then pick out next question. Pick out the cause for late onset hypocalcemia. Remember, less than 72 hours, more than 72 hours. Less than 72 hours means early onset hypocalcemia. More than 72 hours means late onset hypocalcemia. Right? Late onset hypocalcemia. Remember, preterm is a feature of early onset hypocalcemia. B. Maternal hyperparathyroidism means the parathyroid secreted by the mother will take all the calciums of the just born baby, leading to hypocalcemia. So maternal hyperthyroidism leads to early onset hypocalcemia in newborn. So C also comes here. Infants of diabetic mother means they will be plump, they will be obese. So the demand is high, as a result of which you will get early onset hypocalcemia. So B, C, D are causes for early onset hypocalcemia, whereas cow milk feeding, which contain more phosphorus, and it chelates your calcium, leading on to late onset hypocalcemia. Which one? Cow milk feeding. Remember, what are all the manifestations of hypocalcemia? What are all the manifestations of hypocalcemia? What are all the manifestations of hypocalcemia? The manifestations are, it can manifest as stridor, it can manifest as tetany, it can manifest as neonatal seizures. That seizure is most often clonic seizures. Right. So the cause for late onset hypocalcemia is cow milk feeding. Next question. The following are components of Downey score except. So what do you mean by Downey score? Downey score means to assess respiratory distress. Respiratory distress of newborn. It contains the following parameters: respiratory rate, retractions, air entry, grunting, and then cyanosis. You will give a score of 0, 1, 2 for each and everything. So minimum is 0, maximum is 5 into 2, 10. So when the Downey score 0 to 3 or 4 to 6 or 7 to 10. So 0 to 3 means mild respiratory distress, 4 to 6 means moderate, 7 to 10 means severe respiratory distress. So these are all the parameters of Downey score: rate, retractions, air entry, grunting, oxygen saturation, or otherwise known as cyanosis. But what is the xiphoid retractions? Xiphoid retractions comes under Silverman score. One more score is called Silverman-Anderson score. Silverman-Anderson score. Remember, that is exclusive for preterm. In that we measure, one is again grunting will be added, second nasal flaring will be added, third one is retractions. That retractions mean you will be divided into upper chest, xiphoid, and lower chest retractions. This is Silverman-Anderson score. It is exclusive for preterm. So this upper chest xiphoid, lower chest retraction is mainly meant with Silverman score and not Downey's score. Okay, very important again. Next question. Right. A 3-year-old child born of LSCS indication post-dated pregnancy and failed induction with meconium stained liquor. With tracheal suctioning, developed respiratory distress with a Downey score of 5. The child was started on CPAP, continuous positive airway ventilation. The child did not reveal any hyperinflation. After 24 hours, the distress worsened and the child could not maintain saturation and became cyanosed even with 70% oxygen. On auscultation, the air entry was diminished on the left side. Remember, whenever any child is on non-invasive ventilation like a CPAP or BiPAP or invasive ventilation, When the oxygen saturation is suddenly reduced means you need to think in terms of a condition called DOPE, D-O-P-E. Okay, what is called DOPE? When oxygen saturation reduced, D for displacement of ET tube, displacement of ET tube. O stands for any obstruction of ET tube by secretion, obstruction of ET tube. Okay, and then E stands for equipment failure. E stands for equipment failure, whereas P stands for pneumothorax. P stands for pneumothorax. So this pneumothorax will be easily identified by reduced or absent air entry. Reduced or absent air entry. Whenever any child shows desaturation and air entry is reduced on one side, immediately you need to put one needle drainage. What? You need to put one needle drainage in the second intercostal space just below the clavicle, just below the clavicle. So in this case, look at this, the child is meconium aspirated, mechanically ventilated, so shows sudden desaturation and the air entry was absent on the left side. So you need to suspect pneumothorax and you need to put needle drainage. You need to put needle drainage. So this is about this question with respect to newborn. Next. What is the next question? Pick out the wrong statement about apnea of prematurity. So what is called apnea of prematurity? So any child, any preterm is prone for apnea of prematurity. Why? Because his medullary center is not fully formed. Medullary center is not fully formed. So as a result of which the signals from the central will not arise, leading to central apnea. Second, it can be because of poor tone, the child neck will be flexed, leading to obstructive apnea. And finally, it can be both due to mixed apneas. It can be both due to absence of medullary stimulus as well as obstruction of the peripheral airways. Central apnea, the management is caffeine. My dear friends, the management is caffeine. Caffeine is the one which stimulates the medullary center. Obstructive apnea can be managed by means of CPAP. So what does it mean? The maximum that the treatment that you need to give with respect to apnea of preterm means you need to give caffeine and CPAP. Sometimes what will happen, they will not respond to both caffeine and CPAP, means that is called resistant apnea. In that instance, you need to suspect gastroesophageal reflux and you need to start proton pump inhibitor. So define apnea of preterm. So cessation of breathing for more than 20 seconds along with bradycardia and cyanosis is called apnea of preterm. Remember, apnea of preterm is common between second day to first week. Never ever occurs in the first day of life. If occurs in the first day of life, it is less likely to be due to apnea of preterm. It is due to something else. So apnea spells begin before 24 hours must be wrong. If apnea does not occur during the first 7 days, it is unlikely to recur. Correct. It is due to immaturity of the respiratory control system. Correct. Apnea spells occur more during REM sleep. Why? Because during REM sleep, there are signals from the reticular center to the medullary center or other reticular activating center to reduce the tone of the reticular activating system. Otherwise, sometimes you will get dream during REM sleep. If the tone is not reduced, you will act out your dreams. That's why tone of the body is reduced in REM sleep. that becomes a problem with respect to apnea of preterm also. So remember, the carry home message is apnea of preterm unlikely to occur in the first day of life, and if it resolves within 7 days, it is unlikely to occur after 7 days also. 7 days also. Retinopathy of the prematurity screening is of no use if it is done before dash weeks of postmenstrual age. You all know that all preterm less than 32 weeks, all preterm less than 1000 grams should be subjected for ROP screening. Should be subjected for ROP screening. But when you need to do ROP screening, 2 points you need to remember. When you need to do ROP screening, 2 points. 1 point is 34 weeks of gestational age. 34 weeks of gestational age or 4 weeks after birth, or 4 weeks after birth. Whichever is later. Whichever is later. So what does it mean? Let me give you an example. I have a 28 weeker and I have a 32 weeker. That means a child which is born at 22 weeks and a child which is born at 32 weeks. Then you will do, so I have two options, 28 plus 4, 32, 4 weeks postnatal age, or 34 weeks, whichever is later, whichever is later. So what should I do? For a 28 weeker, I need to do ROP screening at 34 weeks. For a 32 weeker, again I have a choice, 34, again 32 plus 4, 36, whichever is later, 36 weeks, I need to do ROP screening. So by and large, 34 week is the time by which you need to do ROP screening. 34 weeks is the time by which you need to do ROP screening. Right? Right. Next question. A newborn is brought with respiratory distress within 6 hours after birth. The following are true except. So look at this. What is this? It is so obvious that the heart is pushed to the right side, and there are, you could see multiple lumens, intestinal lumens on the left side, and you have stomach shadow on the left hemithorax. So it is a case of congenital diaphragmatic hernia, otherwise known as Bochdalek hernia. Otherwise known as Bochdalek hernia. Otherwise known as Bochdalek hernia. Right? So what is the, so a newborn is brought with respiratory distress within 6 hours after birth. The following are true. Can you give bag and mask ventilation? If you give bag and mask ventilation, the air that you are giving through the bag and mask will enter the esophagus and intestinal cavity, will enter the intestine. As a result of it, the intestine that are present in the chest cavity will be enlarged, leading to the compromisation of your airway. That's why bag and mask ventilation is contraindicated. Bag and mask ventilation is contraindicated. Yes, you can do surgical correction. You remember, your congenital diaphragmatic hernia can be detected antenatally. And remember, since the intestines that is present in the abdomen are shifted to the thoracic cavity, it will be associated with the scaphoid abdomen. It will be associated with the scaphoid abdomen. So the answer for this question, this is a spotter congenital diaphragmatic hernia in which bag and mask ventilation is contraindicated. Next, a 5-year-old child presents with the history of fever on and off for the past 2 weeks and petechial spots all over the body and increasing pallor for the past 1 month. Examination revealed splenomegaly of 2 centimeter below the margin, the most likely diagnosis is. So fever is there. So fever means, in this case, fever means WBC is gone. Pallor means RBC is gone. Peticke means platelet is low. When you have more than one cell line involvement, there are only 3 diagnoses. One is autoimmune. Second one is hypersplenism. Third one is bone marrow failure or bone marrow. Third one is bone marrow failure or bone marrow infiltration. Bone marrow failure or bone marrow infiltration. In this case, the child was having Pancytopenia. The child was having Pancytopenia. But spleen is just 2 centimeter. So it is unlikely be due to hypersplenism, because in hypersplenism you will get a huge spleen. Second one is, it can be due to autoimmune. Autoimmune can be due to SLE, in that you will have Coombs positive hemolytic anemia. And one more condition is bone marrow involvement. Bone marrow involvement means either it can be bone marrow infiltration, or it can be due to bone marrow infiltration, or it can be due to bone marrow failure. Remember, bone marrow failure such as Fanconi will not be associated with hepatosplenomegaly. Organomegaly rules out your bone marrow failure syndrome. Also, organomegaly rules out your, what is that? Rules out your immune thrombocytic penic purpura. So this is bone marrow infiltration, more in favor of acute lymphatic leukemia. When you need to consider acute lymphatic leukemia should be considered whenever you have a pancytopenia along with organomegaly, and in total count will be in 20,000 to 1 lakh something based on the severity. But remember, majority will have lymphocytes rather than neutrophils. So lymphocytic pleocytosis with a reduced hemoglobin and platelet is acute lymphatic leukemia unless otherwise proved. Right. Next question. What are all the genetic risk factors for leukemia? The genetic risk factors of leukemia are Downs, Bloom's, ataxia telangiectasia, along with Friedreich ataxia. So Downs, Bloom's, ataxia telangiectasia, Friedreich ataxia. Okay, and then as also you have Klinefelter syndrome. These are all risk factors for leukemia. Turner syndrome is not a risk factor for acute lymphatic leukemia, but it is a risk factor for gonadoblastoma. Not a risk factor for acute lymphatic leukemia. Downs, Bloom's, Fanconi also. Fanconi is also associated with the increased incidence of acute lymphatic leukemia. Good prognosis of neuroblastoma is associated with good prognosis, bad prognosis. Neuroblastoma is the tumor which arises from neural crust cells. You all know that nowadays the treatment is mainly based on whether the child is having good prognostic factors or bad prognostic factors. Good prognostic factors means less toxic drugs, less duration. Whereas bad prognostic factors mean more toxic drugs, more duration. And at sometimes if you have so many bad prognostic factor, treatment will not be started also. So what are all the good and bad prognostic factor? Remember, NEMOIC amplification is very bad. Chromosomal 1p deletion bad. Diploidy is bad. So what are all the good prognostic factors in neuroblastoma? Very, very important. Good prognostic factors are only two: tyrosine kinase A amplification as well as hyperdiploidy. So the rest of the associations are all associated with the poor prognostic factors. What? Poor prognostic factor. Right. All the following, so next is over. Now neuroblastoma over. Now all the following are unfavorable prognostic factors in acute lymphatic leukemia except. So here unfavorable. Hypodiploidy is an unfavorable. Lack of response to prednisolone at the 1 week of treatment is bad prognostic factor. Lack of response to intrathecal methotrexate is a bad prognostic factor. Whereas trisomy 10. What are all those things? Trisomy 10. Okay, translocation 1421. And then trisomy 4 are associated with the good prognostic factors with respect to acute lymphatic leukemia. Then what is this? A 1-year-old boy presented with the hepatosplenomegaly and delayed milestones. Liver and bone marrow biopsy revealed the presence of histiocytes with the PAS positivity. Electron microscopic examination of these histiocytes is most likely to reveal the presence of, what is this? So here PAS positivity, okay, hepatosplenomegaly and delayed milestones. So what is this? Probably this is a case of Langerhans histiocytosis. What is this tumor? Langerhans histiocytosis. Langerhans histiocytosis is characterized by seborrhea, and then you have hepatosplenomegaly. It can also be present with bilateral exophthalmos, can be characterized by bilateral exophthalmos. If LCH involves your posterior pituitary, it can manifest as diabetes insipidus. So this combination of bilateral exophthalmos, okay, diabetes insipidus, and osteolytic skull lesions. I repeat, osteolytic skull lesions occurs in Langerhans histiocytosis. The microscopy will reveal, okay, your electron microscopy will reveal Birbeck granules. Birbeck granules are otherwise known as tennis racket cells. Okay, now the next question. A 8-week-old child, Vaishali, presented with failure to thrive, cyanosis, tachycardia, tachypnea, hepatomegaly, wide and fixed S2 split, along with ejection systolic murmur in the pulmonary area. X-ray shows cardiomegaly with pulmonary plethora. What is the probable diagnosis? So let me give you a simple clue of how to approach a case of cyanotic congenital heart disease. Whenever you see a case of cyanotic congenital heart disease who failed with the hyperoxia test. Hyperoxia test means you give 100% oxygen, but despite that 10 minutes of 100% oxygen, your oxygen saturation fails to increase. That is called hyperoxia test failed. Then you need to know whether it is pulmonary plethora. Pulmonary plethora means increased pulmonary blood flow, or pulmonary oligemia, that is decreased pulmonary blood flow. that is decreased pulmonary blood flow. Pulmonary plethora means vascular markings will be seen. The causes are total anomalous pulmonary venous connection, transposition of great arteries, and then truncus arteriosus. Whereas reduced pulmonary blood flow means there will not be any vascular markings and the lung will be black. Examples of tetralogy of Fallot, tricuspid atresia, pulmonary atresia, and then Epstein's anomaly. So let me give you a simple clue how to find out these congenital heart disease. It's very easy. Point number 1. So how to find out TGA, transposition of great arteries, means no murmur, but cyanosis will be there, CCF will be there, plus egg on side heart. This is TGA. Second one is total anomalous pulmonary venous connection. Here you will have AST murmur. AST murmur means what? You will have S2 split, widen, fixed, split. Along with that, figure of 8 appearance. That is total anomalous pulmonary venous connection. All pulmonary veins will be drained into right atrium rather than left atrium. 3. Okay, TGA, TABC. Then you have tetralogy of Fallot. Here there will be cyanosis along with normal heart size. There will not be any cardiomegaly. Normal heart size. Remember, in case of TGA, TABC, you will have cardiomegaly. But here, normal heart size, cyanosis plus boot-shaped heart. This is your tetralogy of Fallot. Okay. Then comes your TGA. Then comes your tricuspid atresia. Here also cyanosis will be intense. Here also normal heart size. In the first two, increased heart size. In the 3 and 4, normal heart size plus very important left axis deviation, because totally the right heart, it is nothing but right heart hypoplasia. Tricuspid atresia. And finally atresia. And finally you have Epstein's anomaly. This is characterized by massive heart. Or box-shaped heart. Okay, right. So this is the general approach to a very important, my dear friends. You can take a screenshot of this one. A simple approach to cyanotic congenital heart disease. So you can apply this formula and you can find out at least one answer among these 5 scenarios. Next question. A 2-day-old neonate presents to the emergency department in shock. The skin is grayish blue in color. All peripheral pulses are weak. So if all peripheral pulses are weak means what? Very simple. Remember, whenever any child with the shock comes, let me tell you, whenever any child with the newborn with the shocks comes, whenever any newborn with the shock comes, you need to look for, so this is right side, this is left side. So here right side brachial artery, femoral artery, left side brachial artery, femoral artery. So this is brachial, femoral. When both brachials are present, and femorals are absent, it is nothing but coarctation of aorta. It is nothing but coarctation of aorta. But when both all brachials absent, femoral absent, means it is hypoplastic left heart syndrome. All peripheral pulses absent means hypoplastic left heart syndrome. For hypoplastic left heart syndrome, the treatment is Norwood procedure. Whereas in coarctation of aorta, the treatment is surgical excision of the segment. It is not balloon dilatation. Surgical excision of the segment. So here the clue is, look at this. All four peripheral pulses are weak. So this is a case of hypoplastic left heart syndrome. And the treatment of choice is Norwood procedure. Balloon dilatation of aortic valve is done in coarctation of aorta, that is recoarctation of aorta. Whereas Rashkin balloon atrial septostomy is done in transposition of great arteries. Where since there is no murmur, no place for the blood to mix with the right and left area, you will create an artificial hole in the atrial septum. All the following are features of Pompey's disease. Next question. All the following are features of Pompey's disease. What is mean by Pompey's disease? Pompey's disease is due to glycogen storage disease type 2 or type B. It is due to absence of acid maltase. It is characterized by a triad of floppy infant, large heart, and then massive cardiomegaly. Remember, only two things that can cause massive cardiomegaly in newborn. One is Pompey's disease and another is Epstein's anomaly. So what is the answer for this? Pompey's disease presentation in infancy, yes. Short PR interval, yes. Massive QRS voltage because of massive heart, so yes. Is it dilated cardiomyopathy? No. Your glycogen is deposited in the myocardium, leading to restrictive cardiomyopathy, and it is not dilative, it is restrictive cardiomyopathy. The answer for this question is, it is not Pompey's disease is characterized by restrictive cardiomyopathy and not dilated cardiomyopathy. Next question. A boy with persistent eczema, recurrent painless abscess and asthma should be screened for, it was already told to you, hyper IgE syndrome. Chronic granulomatous disease is characterized by catalase positive organisms. Catalase positive organisms. Catalase positive organisms. It is characterized by invasive aspergillosis. Characterized by invasive aspergillosis. One is catalase positive organisms. Next one is invasive aspergillosis. And chronic granulomatous disease is characterized by deep-seated abscess. Deep-seated abscess. It is due to deficiency of NADPH oxidase. And what is the investigation of choice? Nitroblue tetrazolium test is screening test, whereas a dihydrorhodamine test is confirmatory. So what about ataxia telangiectasia? It is characterized by reduced IgA, increased alpha fetoprotein. It is characterized by ataxia, and it is characterized by ataxia, and you have ocular telangiectasia. Telangiectasia, right? Then severe combined immunodeficiency. Kid is characterized by persistent pneumonia, persistent diarrhea between 2 to 6 months. And it is characterized by pneumocystis carinii pneumonia, and in this condition there will be absent thymus. You will get absent thymus. Okay, right. So this question is over. The shape of the mass palpated in idiopathic hypertrophic pyloric stenosis is, you all know that whenever any male comes with recurrent vomiting that start by about 4th week and presenting with hypochloremia, presents with hypochloremia, hypokalemia, chloride will be chloride, potassium, sodium as well as hydrogen will be decreased. Okay, hydrogen will be decreased. So this is called as what? Congenital hypertrophic pyloric stenosis. What is the pathognomonic? Olive shaped mass. Remember, olive shaped mass. Mass while feeding is pathognomonic of congenital pyloric hypertrophic stenosis. So it is olive shaped mass, congenital hypertrophic pyloric stenosis. Next question. All the followings are manifestations of Hirschsprung's disease. So you all know that. What do you mean by Hirschsprung's disease? Hirschsprung's disease is characterized by absent ganglion. You have two plexus, Ayurba plexus and Meissner's plexus. Ayurba plexus is for peristalsis, whereas Meissner's plexus for secretion. Both of them will be lost in Hirschsprung's disease. Here, what will happen? Constipation since birth. Constipation since birth. Remember, you have in barium enema, you will have a transition zone. In barium enema, you will have a transition zone. Right? And then what will happen? Transition zone. So in biopsy, you will get absent ganglion cells as well as hypertrophied nerve fibers. Apart from that, then what is the main difference between habitual constipation due to much of biscuit eating as well as Hirschsprung's disease? Habitual constipation onset usually after 6 months, whereas in Hirschsprung's disease, the constipation since birth. In habitual constipation, your perirectal examination reveals loaded colon, whereas in Hirschsprung's disease, you will have empty rectum. So rectum size will be small. Rectum size, take a snapshot. Rectum size will be small. So all the following are features of Hirschsprung disease. Ganglions are absent. Correct. There may be episodes of enterocolitis. The answer is yes. Because of chronic accumulation of feces, the bacteria that is present in the feces will invade the intestinal lumen, leading on to enterocolitis. On perirectal examination, the rectum is empty. Correct. Rectosigmoid ratio more than 1. No, if rectum is empty, how come a rectosigmoid ratio will be more than 1? It is less than 1. So answer for this one is wrong. Right? Then the osmolality of glucose. In WHO ORS. So you have old ORS and new ORS. Old ORS mainly meant for cholera, whereas new ORS mainly meant to treat rotaviral diarrhea. In old ORS, what will happen? There is more sodium loss due to cholera, more sugar loss, whereas this becomes less in new rotavirus induced diarrhea. So initially what happened, the osmolality of glucose in WHO ORS. So old ORS, what is the osmolality of old ORS? Osmolality of old ORS is 311 old. It has been reduced to 245 in new ORS. It has been reduced to 245 in new ORS. And Risomol rehydration solution for malnourished children, it is usually 300 milliosmol per kilogram. So 311, 300 and then 245. 245 is new ORS, 300 is old, 311 is old ORS, and then old ORS. Okay, and then 300 is for Risomol. 300 is for Risomol. This is all about your new ORS. New ORS. Next question. All the following are true about celiac disease except villus atrophy with crypt hyperplasia is pathognomonic of celiac. What is called celiac disease? Celiac disease is due to gliadin sensitivity, which is mainly present in wheat, barley, as well as rye. Okay, so what will happen when you take it? It will injure your intestinal lumen, leading on to T lymphocyte proliferation in the submucosa, leading on to malabsorption. The most common extraintestinal so what will happen? Any malabsorption will lead to loose stools. Any malabsorption will lead to loose stools. Here, the most common site of injury is duodenum. Most common site of injury is duodenum, where iron is absorbed. So what will happen? Even when you give iron, you will have iron resistant iron deficiency anemia. Iron resistant iron deficiency anemia. So when will you diagnose celiac disease? Whenever you have a combination of pallor plus short stature, pallor plus short stature plus diarrhea, the diagnosis is celiac disease. The diagnosis is celiac disease. Diagnosis is celiac disease. Second point, the investigation of choice is IgA transglutaminase, ETG, IgA transglutaminase or IgG transglutaminase. Serology is the investigation of choice. It occurs exclusively in HLA DQ2 and HLA DQ8 persons. DQ2 to HLA DQ8 persons. Okay, and remember previously they used to do intestinal biopsy to look for total villus atrophy, but now it is replaced by doing HLA DQ2 DQ8 and doing anti-endomysial antibody. When you demonstrate anti-endomysial antibody and HLA DQ2 DQ8, there is no need to do intestinal biopsy to show total villus atrophy. Okay, remember, so this is also correct. Remember gluten-free diet of less than 20 parts per million is the treatment of choice. Villus atrophy can occur in many conditions, not only in celiac disease. Okay, so these points are very, very important with respect to celiac disease. Then, the most common cause for intestinal obstruction between 3 months to 6 years is, okay, remember the most common cause for intestinal obstruction is intussusception. Any child with a vomiting and recurrent jelly stools, along with the sausage shaped mass in abdomen is intussusception. Okay, Hirschsprung's disease, constipation since birth. Constipation since birth is Hirschsprung's disease. Malrotation, any newborn with bilious vomiting. Any newborn with bilious vomiting is constipation. Foreign body lung should be suspected when you have absent air entry in one lung, sudden onset cough. Sudden onset cough. Okay, this is all about your intussusception and other things which are mentioned here. Okay, now next question. Right. The reduction of jaundice after administration. The reduction of jaundice after administration of phenobarbital. The reduction of jaundice after administration of phenobarbital is seen in. Remember when you need to consider. So when you have isolated, let me teach you this way. When you have a isolated hyperbilirubinemia, when you have isolated hyperbilirubinemia, that means your OT is normal, your alkaline phosphate is normal, your PT is normal. In this situation, you have isolated hyperbilirubinemia, means it can be either indirect or it can be due to direct. Indirect means Crigler-Najjar syndrome and then Gilbert syndrome. Whereas direct means you have Dubin-Johnson and Rotar syndrome. Uh, in Crigler-Najjar 2, there will be some glucuronide transferase which can be stimulated by giving phenobarbital. So the answer for this question is Crigler-Najjar syndrome type 2, phenobarbital, that can produce some reduction of jaundice. Okay, triangular cut sign is seen in. Remember, whenever you have pale stools, remember a combination of pale stools plus yellow urine, colored urine. Pale stools, colored urine means you need to take an ultrasound in the newborn. It can show a choledochal cyst. Or it can show triangular cut sign which occurs in extrahepatic biliary atresia. So the answer is a biliary atresia. Triangular cut sign is seen in biliary atresia. Next question. Which is the wrong statement about Wilson's disease from the following? You all know that Wilson's disease is due to increased copper. So increased what copper? Increased copper, particularly increased urinary copper, not blood copper. Urinary copper after penicillamine. Or it can be done through liver biopsy. So which can show more than 3.2 milligram per gram of dry weight of liver, that is your copper. So urinary copper you can do, liver biopsy you can do. The simple test is reduced serum ceruloplasmin less than 20 milligram per deciliter. Serum ceruloplasmin, even though it is not a specific test, we do serum ceruloplasmin. So you can get KF ring in eyes. Your basal ganglia can be affected, leading to involuntary movements, and your RBC will be affected, leading on to acute hemolysis. Your RBC can be affected and finally your liver. Any form of liver injury can occur. Any form of liver injury can occur. Form of liver injury can occur with respect to Wilson's disease except one. What is that? Cholestasis will not occur. Other things can happen. Other things can happen. Okay. So what is that? Kaiser-Fleischer link. What is the treatment of choice? What is the treatment of choice? Zinc can reduce absorption of copper from the food. Second one is trientin. Trientin is the copper chelator. Third one is penicillamine. Penicillamine is a copper chelator. Penicillamine. So trientin, penicillamine. Third one is for neuro-Wilson. Ammonium tetrathiomolybdate. Ammonium tetrathiomolybdate. Ammonium tetrathiomolybdate. That is for neuro-Wilson. Remember, at the end stage, you need to go for liver transplantation. Kaiser-Fleischer always present in patients with neurological symptoms. Yes. Even after chelation therapy, Kaiser-Fleischer do not disappear. No, it is wrong. After chelation, KF ring will disappear. Liver transplantation, yes, may be needed. More the genes knockout mean early onset. So the answer for this one is KF ring will disappear after chelation therapy. Chelation therapy. What is called rope sign? Rope sign is due to this one. This is okay. It occurs in bulbar poliomyelitis. I don't want to go deep into it. We don't see poliomyelitis right now. Rope sign is an acute angulation formed at the neck due to bulbar poliomyelitis. Quantiferon gold test is used to diagnose which test? Remember, what are all the tests for TB? What are all the tests for TB? So the direct test for TB, one is smear, second one is culture, one is smear, second one is culture, third one is PCR test. Smear is AFP smear, we often do, but in resource poor setting. Culture means you have solid culture and then liquid culture. Liquid culture. Solid culture is LJ medium, we don't do nowadays. Liquid culture is MG80, mycobacterial growth inhibitor. It is the gold standard test right now. It is the gold standard test right now. Which one? Liquid culture. PCR means two tests. One is CB0, nucleic acid amplification test. Another is line probe assay. CB0 you will get results within 2 hours. And it will show whether rifampicin is resistant or not. LPA will take 2 days and it will show all resistance form. All resistance form. These are all direct tests. It will pick up the microorganism. It will pick up the microorganism. What are all the indirect tests? What are all the indirect tests? Indirect test means indirect test. Indirect test means it will find out infection but not microorganism. So what are all the tests? One is Mantoux test. That is a skin test. Second one is IGRA, interferon gamma assay. That is called quantiferon gold test. So this is the test which you measure interferon gamma that is released in the blood. So this is the only investigation of TB that is done with blood. And the third test is CTB test. C stands for Copenhagen test. So here they will use ESAT CFP protein specific for Mycobacterium tuberculosis as Mantoux test. Instead of using purified protein derivative, they will use ESAT and CFP protein. Okay. ESAT and CFP protein. Right. So direct test and indirect test. So quantiferon gold test is mainly meant to find out tuberculosis, and it is the only blood test. All other tests either utilizes skin or your tissue sample or sputum or fluid. No, blood is usually not utilized. Right. Rapid diagnostic tests for detection of malarial antigen are mainly based on so your histidine rich protein, your lactate dehydrogenase and aldolase, plasmodium, okay, plasmodium malariae, whereas histidine rich protein is plasmodium falciparum. So when you get one, it is just like a pregnancy car test. If you get one line, it can be a malarial species. If you get two lines, it can be due to Plasmodium falciparum also. That the second line is mainly due to the presence of histidine rich protein that is present in falciparum malaria. Which of the following is not a component of congenital toxoplasmosis? Congenital toxoplasmosis is characterized by three C's. One is chorioretinitis, another is intracerebral calcification, and another is hydrocephalus. So here it is diffuse calcification. Even though deafness do occur in toxoplasmosis, it not necessarily to be present as a triad, in congenital toxoplasmosis. Even though all of them can occur, deafness also occur, but it is not a part of triad of congenital toxoplasmosis. Single most common finding among infants with congenital rubella syndrome. Congenital single most common finding. You will get patent ductus arteriosus, you will get deafness, you will get cataract, but single most is sensory neural deafness. Particularly if the infection occurs within 12 weeks of pregnancy. If it occurs, you need to go for an abortion. Periventricular intracranial calcification. You all know that cytomegalovirus is associated with periventricular calcification, whereas toxoplasmosis is associated with diffuse calcification. So CMB means periventricular, toxoplasmosis means diffuse, whereas your herpes simplex encephalitis is associated with temporal lobe encephalitis. A 4-year-old child presents with pallor. 4-year-old child presents with pallor, lethargy, mild splenomegaly. His hemoglobin is 6, MCV is 64, RBC count is 3.2. What could be the probable diagnosis? 4-year-old child. Okay. So remember the rule of 3. Rule of 3. What is rule of 3? Your hemoglobin is low, your MCV is low, your RBC number is low. When all are proportionately low, you are dealing with iron deficiency anemia, but you will get a high RDW. RDW means increased anisopoikilocytosis. High RDW means more than 14. Whereas when you have disproportionate rule of 3, that is hemoglobin is low, but MCV is also low, let me say less than 70, but RBC number normal. RBC number normal means you are dealing with a case of tall trait. Here your RDW will be normal. So let's see in this case. So I have a hemoglobin of 6, but RBC count is not reduced. But for a hemoglobin of 6, my RBC should be less than 1 million, 2 million. Here it is 3.2 million and MCV is 64. So I have a disproportionate decrease in RBC number. So I am thinking in terms of thalassemia trait. For thalassemia trait, your RDW will be low or normal. So this is a case of thalassemia. To me, it is thalassemia trait, but I don't think nothing is fitting into that. To me, let me say this is thalassemia trait and RDW should be normal. I don't think this is a case of iron deficiency anemia. This must be a case of thalassemia trait. Okay, see, please, I think C should be framed as thalassemia trait along with the normal or low RDW, because other things cannot fit in. If it is a case of thalassemia major, you will have a huge organomegaly. If it is a case of iron deficiency anemia, RBC number still has to be low. Aplastic anemia means you will not have any splenomegaly. I repeat, organomegaly rules out aplastic anemia and immune thrombocytopenic purpura. A 2-year-old child who is a known case of sickle cell anemia presented with painless swelling of both feet. X-ray is normal. What is the ideal treatment? You all know that the most common manifestation or the first manifestations of sickle cell anemia is dactylitis, bilateral symmetrical painful swelling. Dactylitis, the treatment of choice is palliative treatment with analgesics. The treatment of choice is palliative treatment with analgesics. Treatment with analgesics. That's it. Okay, but if you have acute chest syndrome or stroke, the treatment of choice is exchange transfusion. Remember, the treatment of choice in case of acute chest syndrome or a stroke is exchange transfusion, not merely giving a analgesic. And the prevention treatment with respect to sickle cell anemia is giving hydroxyurea, lifelong hydroxyurea. Okay, what is the current recommendation of transfusion therapy for thalassemia children? Remember, you have pre-transfusion hemoglobin and post-transfusion hemoglobin. Pre-transfusion hemoglobin is usually 9.5 grams per deciliter, and post-transfusion hemoglobin should be 12 grams per deciliter, because when you under transfuse, there will be more extramedullary hematopoiesis leading on to Leonine phases, hepatomegaly, splenomegaly. But when you over transfuse, there will be chances for hemochromatosis or hemosiderosis. So ideally, you need to follow a procedure called moderate transfusion. In moderate transfusion, the pre-transfusion hemoglobin is 9.5 and post-transfusion hemoglobin is 12 grams per deciliter. This is very, very important. What is the screening test for secondary hemostasis? So a rapid revision with respect to clotting system. Okay, remember the first step 1. So what is step 1? So step 1 is look for CBC, look for peripheral smear for platelet count. It is not your bleeding time, clotting time. In CBC, more than one cell line affected. More than one cell line affected means it can be due to autoimmune mechanism, or it can be due to hypersplenism, or it can be due to bone marrow infiltration or failure. Remember, only platelet should be affected. If apart from platelet, if hemoglobin and total count also affected, think about autoimmunity, think about bone marrow failure syndrome, and think about hypersplenism. Why peripheral smear for platelet count? Normally in a high power field you will see a clump of platelet. If you see a clump of platelet means it means when you see one platelet count in peripherals, it means more than 15,000 in automated hemogram. So when you see a clump of platelet, it rules out quantitative disorder as well as rules out qualitative disorder. When you see a clump of platelet, it means platelet function is normal, number is normal. But when you see small platelets away from each other, and you can also see large platelets away from each other. When you see large platelet away from each other, it is called Bernard-Sallier syndrome. When you see small platelets away from each other, it is called as Glanzmann thrombosthenia. So remember, by doing simple first step CBC with peripheral smear, you are diagnosing so many things. So what is the next step? So next step is step 2 is prothrombin time. When prothrombin time is increased means either it can be due to vitamin K deficiency or it can be due to liver disease. Then you have your partial thromboplastin time. If partial thromboplastin time is increased means you can have hemophilia A, hemophilia B, hemophilia C, hemophilia D. In hemophilia A, B, C you will get bleeding, whereas in hemophilia D no bleeding at all. No bleeding at all. So third thing is thrombin time. Thrombin time means two diagnoses. One is apparent contamination. Second one is reduced fibrinogen. Reduced fibrinogen. Thrombin time. Finally, when all test normal, but child bleeding. But child bleeding means what are all the manifestation? Factor 13 deficiency, Ehlers-Danlos syndrome, scurvy, or it can be due to child abuse. Very, very important. So within 5 minutes we had covered an approach to bleeding disorder. So the answer for screening the primary hemostasis, secondary hemostasis. Primary hemostatic means platelet plug. Secondary hemostasis means clotting factor. So test for primary hemostasis are bleeding time, platelet count, as well as platelet function analyzer, whereas clotting time is for secondary hemostasis. Remember, we don't do bleeding time, clotting time nowadays. We just do CBC peripheral smear, prothrombin time, partial thromboplastin time, thrombin time. When all tests are normal, what are all the differential possibilities? Okay, next question. A 6-year-old child, minor trauma, developed an hematoma, PT, APTT, everything is normal. And look at this, when everything is normal, when the child is bleeding, it is a case of factor 13 deficiency. When everything is normal, but the child is bleeding means 13 deficiency. Whereas increased partial thromboplastin time, but no bleeding means factor 12 deficiency. 12 deficiency. Next case. A 2-year-old child brought with fever and vomiting for 10 days. The child had a disturbed sleep during night and irritable and not playful during daytime. Yesterday, the child presented with convulsions and treated with antibiotic and anticonvulsant. There is a cranial nerve palsy. Immediately, the child is sent for brain imaging. What is the most probable CT? It's very, very simple. Look here, my dear friends. When you have a fever of more than 7 days, along with headache, along with irritability, and if you have findings such as hydrocephalus, infarct, cranial nerve palsy, or basal exudate, you are dealing with a case of tuberculous meningitis. And in tuberculous meningitis, the treatment is 1 year of ATT treatment. So the answer is basal exudate, infarct, and hydrocephalus. Remember, all subacute meningoencephalitis should be considered for TB unless otherwise proved. So this is a case of tuberculous meningitis. Gower sign is fully expressed by. Gower sign is usually present in, remember, Duchenne muscular dystrophy, characterized by absent dystrophin gene. Characterized by calf hypertrophy. Increased CPK, creatinine phosphokinase in 10,000, 15,000. Gower sign means when the child is asked to stand from sitting position, he or she will use her hands over her leg first, shin, and then thighs, and they will get up. This is called Gower sign. Gower sign is usually established at 6 years of age. Established at 6 years of age. Right, the next question. A 4-year-old child with acute onset fever, irritability, and vomiting for 2 days, present with focal seizures and altered sensorium. CSF analysis revealed mononuclear cells. If you have mononuclear cells, it can be TB or viral, that is your lymphocyte or monocyte. When you have neutrophils, you are more into bacterial. So this must be a case of viral. TB, as I told you, subacute, it takes such a long time. Sugar is not reduced. Remember, sugar is reduced only in which condition? Sugar is reduced in bacterial. Sugar little bit reduced, but not that much reduced. In bacterial, it will be less than 10. Mildly reduced means it will be a 2 viral condition that can produce hypoglycemia. 2 viral condition. Hypoglycemia means reduced CSF sugar and mildly elevated protein. EEG shows lateralized discharges. Lateralized discharges means discharges over the temporal lobe. So temporal lobe encephalitis. Remember, temporal lobe encephalitis, sugar reduced, mildly reduced, protein mildly increased means this is herpes simplex encephalitis. The treatment of choice is acyclovir. Remember, herpes simplex encephalitis is associated with temporal lobe encephalitis, so you will have behavioral disorder. See, only 2 viral conditions that can reduce your CSF sugar. One is CSF sugar. Okay, one is CSF sugar. One is your herpes simplex encephalitis. Another is herpes simplex encephalitis. The one another condition is mumps. Very well. Please remember these 2 points. A 2-year-old boy Lalit with fever, irritability, sore throat, decreased oral intake, stridor, drooling of saliva and torticollis. His voice is muffled and complains of neck pain and refuses to move his neck. Remember, whenever you have dysphagia, dysphonia and drooling of saliva, drooling of in a young child, you need to look for neck movements. Affected, that means restriction of neck movements. Not affected means epiglottitis. The treatment of choice is zone, ceftriaxone, or you can selectively intubate the child. Whereas neck movements affected means it is retropharyngeal abscess. You need to give a combination of ceftriaxone and clindamycin to cover anaerobic organisms. Okay, so this is retropharyngeal abscess. The clue is restriction of neck movements. Finally, in VUR, the dilatation of ureter starts from which stage? So stage 1 is characterized by normal ureter, reflex up to mid ureter. Stage 2 is normal ureter, reflex up to full ureter or up to pelvis. Whereas stage 3, mild dilatation of ureter, stage 4, moderate dilatation of ureter, stage 5, severe dilatation of ureter. So ureter's dilatation starts from which stage? Stage 3. Stage 3. So with this, we have finished our session. I think almost 2 hours are over. Thanks for your patient listening. Bye-bye. Keep watching many more videos so that you can revise easily. Also keep watching my Instagram channel. It is mainly meant for NEET PG revision. You will have at least 5 points in each and every day. Please make use of it. Thank you. Bye-bye.